and pre-biopsy MRI have different roles. Radiologists try to find clinically significant cancer in pre-biopsy MRI, and we can do a targeted biopsy. I drew these schematic figures. Post-biopsy MRI examinations are performed in patients who are diagnosed with prostate cancer, but pre-biopsy MRI is performed first in patients suspected of prostate cancer. So the number of prostate MRI examinations has surged by performing pre-biopsy MRI. It is important to make a good radiology report to answer the clinical questions. PARA suggests a report template. It includes indication, technique, comparison, and findings. The first part of the finding is the size of the prostate gland, and the question may be, what is the size of the prostate gland? Detailed findings of the lesion should be reported. They are the answers to many questions. And the last part is to determine how severe the cancer is. So I thought that AI in prostate MRI should be developed to answer these questions, and AI should complete individual mission to provide answer to each question. There are many articles about the AI algorithms in prostate MRI, but I will skip the summary of the previous studies. Let's move on to the main topic, AI prostate. I could use AI prostate at the beginning of the development. The first version was released in February 2019. After that, update versions were released very rapidly. The MR prostate AI prototype supports accelerated reading of multiparametric prostate MRI. The prototype provides automatic prostate segmentation. It detects focal lesions that are suspicious for clinically significant cancer and classifies the lesions according to PARAs. So AI prostate can answer most of clinical questions. Essential data for processing is T2-weighted imaging and DWI. ADC and DC images can be optionally loaded. After loading the images, we can start processing. It takes about 16 seconds and about 40 seconds to process PP and MP MRI respectively. By using MP MRI, we can get K-transmap too. The program shows many lesion details such as diameter and PARAS classification. It also automatically identifies the location of the lesion. We can also get the prostate gland volume. Let's look at this case together. There is a small diffusion-restricted lesion in the left peripheral zone, apex. The abnormal region is well marked on T2-weighted image. Users can modify the ROI as they want. The lesion was classified as PARAS 4, and the diameter was 7.9 mm. We also get the volume of the tumor. The location of the lesion was automatically selected as peripheral zone, apex, left, and posterior. The prostate gland volume in this patient is 23.8 milliliter. When I enter the patient's PSA level, PSA density is calculated because the algorithm can measure the prostate volume. A targeted biopsy was performed for the lesion, and Gleason score 7 cancer was confirmed. I summarize the strengths of AI prostate. Prostate gland segmentation is an important strength. Prostate gland volume can be measured based on prostate gland segmentation. As you saw, when I enter the PSA level in the program, it calculates PSA density immediately and displays the value with different colors that indicate different risk of prostate cancer. You can choose not to see or see the segmentation results. It provides segmentation of the entire prostate gland and central gland separately. Also, exporting the segmentation masks is possible. We can get masks of the lesion, the entire prostate gland, and the central gland. We can get a report that includes all lesion details and snapshots taken on the section where the lesion appears to the great. I tested the early versions of AI prostate. In the first versions, there were some problems. First, A few small lesions were detected in a large prostate cancer. This problem was solved in the later version. Inaccurate prostate segmentation was observed in more than 17% of patients. In 2 patients, segmentation was failed. However, in the later version, segmentation was accurate in most of patients. The prostate gland volume was measured so large that it was almost impossible. This problem was also solved as the developer discovered an error in the volume calculation process. As the AI had evolved, the performance also had been improved. The process became faster and more stable. There was no Pyro3 lesions in the early version, but Pyro3 lesions in the later version were agreeable in most patients. Also, the number of false positive lesions decreased. The false positive lesions that AI detected could be classified into several categories. The first types are those found in the central zone. These areas are very famous for mimicking prostate cancer. AI also misjudged the areas as prostate cancer. The second types are those found in the T2 low signal intensity area around the ejaculatory duct. The third types are BPH nodules. Another mistake in the early versions was that the AI could not detect very huge cancer. This patient's PSA level was higher than 2,000 nanogram per milliliter. So it is very rare that patients like him undergo prostate pre-biopsy MRI to find focal prostate cancer. I will show you the results of the updated prototype. Prostate pre-biopsy MRI examinations were used, and trust-guided biopsy results were referenced as gold standards. MRI examinations from Siemens 3T MRI machines were evaluated. Somebody may want to know why I used only MRI examination from Siemens MRI. In my hospital, there is another vendor's MRI machine, but the signal intensity on diffusion-weighted image were very strange, so the results were not reliable, and I excluded all examinations obtained from the machine. I used biparametric MRI images. As I wanted to compare the diagnostic performance between AI and radiologists with various levels of experience, residents and radiologists reviewed the MRIs. One examination did not run in the program because T2 and DWI images had different UID. I also excluded patients with very high PSA level. Among the patients, 39 patients were diagnosed with clinically significant cancers. Interestingly, residents detect many false positive lesions similar to the early versions of AI. The first mistake is detecting false positive lesions in the central zone. The second type of the false positive was in low signal intensity area around the ejaculatory duct. The last one was detecting BPH nodules as prostate cancer, so AI and residents make similar mistakes. The mistake that AI could not detect huge mass was fixed in the updated version, even though the result was not perfect. So AI prostate showed much less false positive lesions than before. AI detected only 58 lesions in 121 patients. In per-patient analysis, the cancer detection rate of AI was 72% and 68% in PARAS 4 and 5 respectively. The right side table was the results of my review. The most noticeable difference between radiologists and AI is the proportion of PARAS 2 and 3. As prostate AI's purpose was not to detect PARAS 2 lesion, no PARAS 2 lesion is understandable. In AI, PARAS 3 lesions were detected only 0.8% of patients. The sensitivity and specificity of AI was 71% and 84% respectively. The sensitivity of AI was higher than Group 2, but lower than other radiologists. The specificity of AI was significantly higher than G1, G2, and R3. Accuracy of AI is about 80%, and it was similar to the most experienced radiologist. Let's see some cases. In this patient, there is a small diffusion restrict lesion in right peripheral zone. 3 radiologists detect the lesion, but AI couldn't. In the second patient, there was a focal diffusion restrict lesion in left peripheral zone, and only L4 and 5 detected the lesion. In this case, ill-defined T2 low signal intensity lesion was in left transition zone, and the area shows high signal intensity on diffusion-weighted image and low signal intensity on the ADC map. This lesion was detected by AI. Among radiologists, only L4 could detect the lesion. So in some cases, AI missed prostate cancer, but sometimes AI could detect the focal lesion that was missed by most of the radiologists. The diagnostic performance of AI was also compared with the clinical routine report. The MRI examinations were obtained in 2 hospitals by using one of these machines. In this study, MRI examination from G machine were included. Clinically significant cancer were diagnosed in 55% of patients. In clinical routine, 10 board-certified radiologists read the images. 1 radiologist performed the retrospective review. The difference in the proportion of PIRAS classification was also noted in this analysis. In clinical routine, PIRAS 4 was much more, and PIRAS 1 was much less than AI and retrospective review. The cancer detection rate of PIRAS 4 in clinical routine was the lowest among 3 readings. The proportion of missed prostate cancer in clinical routine and AI results were similar to each other. The weighted kappa value was highest between AI and retrospective review. Sensitivity of 3 results was higher than 85%. The specificity of AI was higher than the clinical routine MR report, so at least prostate AI showed similar sensitivity to clinical routine reports and better specificity. In this case, what is your PIRA score? PIRA score in the clinical report was 1. The patient's PSA level was very high, and the entire prostate gland was replaced by prostate cancer. AI could detect the lesion, and the PIRA score was 5. In the second case, what is your PIRA score? PIRA score was 1 in the clinical report, but AI detected a small lesion in the transition zone and classified the lesion as PIRAS 4. There was clinically significant prostate cancer in the corresponding area. In this case, what is your PIRA score? There is small T2 low signal intensity lesion with diffusion restriction in left peripheral zone. Radiologists could detect the lesion, but AI could not detect the lesion. It seems that prostate segmentation did not cover the entire lesion. I was curious about the accuracy of the prostate volume measured by AI. So I compared the prostate volume measured by AI and measured in MRI and ultrasound in the clinical routine. I measured the volume retrospectively on MRI and ultrasound too. In the clinical report and my retrospective review, the ellipsoid formula was used. The prostate gland's weight was collected from the pathology results. Prostate gland volume measured by AI showed the second highest ICC with the prostate gland's weight. The graph also showed the good correlation between volume measured by AI and the prostate gland's weight. It's a preliminary result, and I'm not sure how I can set a solid reference for prostate volume. Anyway, I believe that a volume measurement by AI is reliable. My overall impression of AI is as follows. It showed similar perform clinical routine reports with better specificity. It takes a very short time to process and analyze the images. It provides some convenient functions. However, we should think about the important premise. Good image quality is very important. In this case, geometric distortion from rectal distension was noted on DWI, and images were misregistered. As a result, artifact in the left peripheral zone on DWI was detected as a Paras 4 lesion in the left transition zone on T2-edited image. An important challenge of prostate AI is multiple MRI vendors. MRI images from different vendors, machines have a different texture, and it may affect the diagnostic performance of AI. So collecting data from many institutions is important. However, AI prostate could detect prostate cancer accurately in other vendors' MRI images. Another problem is the ground truth. Radiologists' interpretation and pathology results can be used as ground truth, but we don't know which is better, and both of them have pros and cons. The IDER process in the clinical workflow is another important challenge for prostate AI. When we read the MR images, AI reports should be prepared and is presented with MR images. In summary, AI prostate can answer to most clinical questions. AI algorithm has been improved rapidly and it shows good performance. However, more training with tricky cases is necessary for much better performance. Still, there are some challenges for AI prostate to spread widely. Thank you very much.
Yeah, thank you very much for your very insightful talk, and I can only say that we are exactly working also in this direction to gain more data to better train the networks, but it was very interesting to hear from you which progress has been made, but it also shows that it is quite some effort to get something as AI working on multiple data sets and multi-vendor data sets and so on. I have one short question which is not directly related, but I would be interested how you perform your biopsies locally. Is it fusion biopsies, or which method are you using?
In my hospital, radiologists perform all prostate biopsy, and we use MR and ultrasound fusion biopsy.
Okay. I mean, the segmentation of the prostates with an automated tool could also be helpful there, and also the PSA density calculation, as you pointed out, that it's more accurate if you segment the prostate and so on. And out of curiosity, you were mentioning that the less experienced readers improve their performance. Did they also like to use the tool? Did they were reassured with using the software?
Yeah, I think so. And actually, I wanted to evaluate the residents' diagnostic performance because there are many radiologists who, old radiologists who had no adequate training when they were residents, and they had few experience in MRI prostate. So, and I think that they can be sure after reading the AI prostate results. And actually, it can the result AI affect radiologist reading negatively. But when I evaluate the AI prostate's performance, I'm sure that it will be very helpful for residents because they can think about their review one more after reading the AI results.
Okay, thank you. With that, I think we have to move on to the next presenter.
Of abdominal MRI. The title of the lecture is Active Surveillance with MRI, and he will discuss the role of MRI in active surveillance in prostate cancer.